Let's start with the first session by Dr. Tim Cressey. All right, he's there. Okay. Dr. Tim Cressey is actually the clinical pharmacologist, but we always think he's like clinicians. But he has been working with patients, particularly pediatric and adolescent population with HIV for a long time. He is the faculty associated of Associated Medical Science at Chiang University in Thailand since 2001. His family is here in Thailand, in Chiang Mai, very lovely two kids. While in Thailand, he held a joint academic position at the Harvard Chan School of Public Health in the US, and currently hold the position of the French National Research Institute for Development PHPT Research Unit and the University of the Liverpool, UK. So Tim has been good long friend with all of us in this region, not just in Thailand. He's working a lot on pharmacokinetics for antiretroviral therapy. And today, Tim will be the first person, and he will be speaking about the novel antiretroviral drugs and therapeutics for prevention and treatment across the pediatric age continuum. So Tim, please.
Okay. Thank you very much, Dr. Gunkanya, for the kind introduction. I'm very happy to be here. I'm very happy to be part of this very interesting session this afternoon, and it's my role at the beginning of this session just to give you a little bit of an update about, the new drugs or the drugs that we have available for HIV prevention and treatment, and then starting from birth all the way to through adolescence. So we're going to go on a little bit of a journey across these different ages, and there isn't a timer here. So Gunkanya, if I'm going too late, just shout at me. It's okay. Don't worry. Okay, let's go. So I have nothing to disclose. So firstly, just to give one slide on the update of, the epidemic, specifically in pediatrics. And this data is from the UNAIDS report last year. And what this graph's showing here is that the orange line, which is a little bit strange to put in the report, but what they're trying to show is that if we didn't give ARVs to pregnant women and during breastfeeding, you would have, continued on that orange line. But actually we did, as since about from single-dose nevirapine AZT and then triple ART now. So we've saved about 3.4 million new infections in children. But what's interesting, and maybe this is why they put it on to distract, is that if you look at the green line, yes, we got that big reduction early on from about 2004 when, PMTCT across the world was implemented. And then even since 2012, where you have 85% of mothers who become pregnant living with HIV on treatment, the levels are still not dropping as fast as we would like. So this is why we still had last year, globally, around 130,000 new infections in children between 0 and 14 years. Obviously, most of them were on the younger side, and the majority in sub-Saharan Africa and in Asia has done a great job in having fewer infections of that proportion across the world. But where are these new infections occurring? If you look at this stacked bar on the right-hand side, we see how that 130,000 is basically split. So as you would expect, the majority of that 130,000, 65,000, is because the mother didn't receive ART. Then you have some, at the top in the red, about 30,000 because maybe they were not identified or positive during pregnancy, and then they were identified late, or they had primary infection during pregnancy. This is perhaps an advocate to test several times during pregnancy. And then there's the other ones, which is we have more about, the treatment using ART. People stop ART, some are on ART, but not detectable. But you can see that there's still quite a few challenges to get, the number of infections to decrease more and more. One good point is that that one I've just added on is that our early EID or early infant diagnosis is now globally, so there's around 60% of those infants born to mothers living with HIV have a test within 2 months of life. That's around about 60% now. So that's a good increase, so that we'll be able to identify these children quickly. And I put one slide in here. This is from Dr. Annette Snoggin's slides from last year at the AIDS meetings. And just to show the Thai data specifically, and she can comment more about the Asian population, but we can see that in the data they have from the Treat Asia cohort, where they have around, over the last 15 years, around 6,000 diagnosed. Now the median ages are getting older. If you look at the pie chart, you see the good news in some way is that the number of children, less than 4 years of age because of the good prevention programs is now very low. And now this cohort of HIV, children living with HIV is now aging and they're becoming more adolescents and young adults. So that's how we're moving. And most of them, again, 65% are doing quite well on treatment with undetectable viral load. So this is the current status in Thailand. So what I'm going to try to do over the next 25 minutes or so is just give you an overview of what we've come a long way when it comes to treating HIV from, neonates all the way to adolescents. So I'm going to try to say, like, we started with syrups. So syrups we, still do to some extent for the neonates. Then, we've made granules now moving forward. We have suspensions and granules, these oral granules. Then we have dispersible tablets as we move up the age. They can be more useful and more child-friendly. Potentially oral films in the future. This is a novel administrational method that I'll have a couple of slides on. Then we come to the fixed dose combinations, which we know have been very effective in the adolescents, but we want to see, how much we can utilize them across the ages. And then moving forward, we have the long-acting agents, whether these are intramuscular injections of small molecules like carbapenem, pivirine, or long-acting, broadly neutralizing antibodies. So what we've done now, we've changed a lot. So originally we had the syrups, and then we've moved on to these novel regimens through advocacy of everyone in this room saying we need dispersible tablets, we need granule formulations. So it's been a huge undertaking and a very successful one at that. But what we still want to do is we want to move all of these formulations down. We want to use long-acting into the adults, adolescents, and the young children. We want to move the fixed dose combinations lower. We want to move the dispersibles. Can we use them lower and lower? And can we even use the granules and other formulations that have been produced, which were developed for children, but can we then even see if we can utilize them for neonates? And that's where we're going to try to walk you through each of these situations and the drugs that are available to see what we achieved and what we are looking forward to in the future. So let's start with the neonates first. And when we talk about neonates, it's become a little bit of a blurred situation when we look at ARV prophylaxis and treatment. In the past, we had specific ARV postnatal prophylaxis, single dose, nevirapine or zidovudine or both. And now with treatment, we have the triple drug regimens. And over the years, and I picked a bridge from Thailand because we're in Thailand, we have this bridge now between ARV prophylaxis and treatment where the lines are becoming a little bit blurred. As you treat for high-risk infants, triple drug regimens, a lot of the drugs we're investigating for treatment could probably be used also for postnatal prophylaxis. So that's why I'm saying nowadays when we're talking about drugs for neonates, it's likely they could be used for either treatment and or prophylaxis depending on the situation in the mother. Here are the current guidelines, and I picked three. I picked the US guidelines, the WHO in the middle, and the Thai guidelines on the right. And just to show you the difference for neonates, the difference between the treatment regimen and the infant prophylaxis regimen. I'm not going to go through all of them in detail, but we wanted to highlight, if I have a pointer, I don't know. Oh no, I'm going backwards now, sorry. I will not touch the pointer, it's too risky. We'll do the neonates. So you see the US and the WHO are both using for treatment 2 NRTIs plus raltegravir with the oral suspension. Well, for Thailand, they're using for treatment triple drug regimens, but they're using lopinavir or DTG dispersible tablet, depending on the age they identified. While we look at the prophylaxis, again, it's mainly focusing on zidovudine and nevirapine, especially for the WHO in Thailand. And while these have been exceptional drugs for prevention of mother-to-child transmission and are still widely used, the WHO still recommends zidovudine and nevirapine, even for high risk. The question is, can we move away from AZT and nevirapine? The stocks for these, the procurement of these drugs and liquids is getting harder. So when we're thinking of this, benefit, prophylaxis versus treatment, how can we perhaps use some of the most novel drugs to see if we can use them for neonates as well? So one of the things I would just pick one example, and here's a slide of looking at, if you take from the NNRTI specifically along the right-hand side, the common ones, and the lines are showing the age at which those drugs are approved at the regulatory level, they say the US FDA, and you can see a lot of them like TDF has stopped at 2 years, while we have, zidovudine goes all the way down to 4 weeks, but then for treatment. But if we look at the term neonates, one of the ones that was missing, which is commonly used across Asia and in other settings, is abacavir. So one thing we were able to do over the last 2 years was to look at abacavir liquid formulation in neonates from birth. This was a study done through the Impact Network in the US, and it was primarily enrolling in South Africa. And what this figure shows on the left, that they gave liquid abacavir during the first week of life. These are some studies with the triangles and the dots. And this graph is showing on the y-axis is the oral clearance of the drug, so how well it's removed from the body. And then it's on the x-axis is the age, so going from birth all the way up to about 9 months. So as you can see, is that the way the drugs metabolize, or the clearance, when you have those red squares and triangles, the clearance or the metabolism by that neonate at birth is very, very slow, but it quickly increases. You can see that the way that the neonate metabolizes it almost increases 5-fold over the first month of life. So, when you're giving these drugs, it's quite hard to, get the right dose, because the way the child is metabolizing, or the baby's metabolism, is changing very fast. But we were able to come up with some dosing recommendations for abacavir from birth. And in the WHO guidelines, if you look now, there is guidelines to use liquid abacavir from birth using a weight band dosing. Again, it's not widely used because everybody uses AZT or 3TC. But if you wanted to start treatment earlier now, and you didn't want to start zidovudine and then switch to abacavir, for example, which is a lot what they do often in South Africa, you could push that abacavir lower if needed. And again, there is some dosing guidelines associated with that. But we've always tried to move away liquids. I'm talking about liquids, but I've talked to Tanui and Gunkanya for years that we should stop using liquids, and everyone's agreed. And what we've done for many years is to see if we could use solid formulations which were developed for children, and then that helps. We have the lopinavir granules here from Vitaris. We have the dispersible tablets as well, and these all of these formulations actually, where we have double scored abacavir 3TC. And these have been very, very well received and are used widely around the world for children living with HIV. But one of the things we thought about was, could we use these in neonates? So starting these combinations from birth rather than using the liquid formulations, whether for prophylaxis or treatment. And one of the things I set up with a colleague of mine, Professor Adri Becker at the University of Stellenbosch in Cape Town about 3 or 4 years ago, is what we set up something called the Petite X platform. And petite obviously is because it's to do with neonates. And this is a collaboration where we have clinical sites in South Africa, Thailand, and we have, working on trying to study these fixed dose combinations that in children, to see if we can use them in neonates. And this is work funded through UNITED. And we've done several studies. And the first one we did is we tried to, and this was a few years ago now, where there was a lot of work done on a 4-in-1 formulation. This was developed by CIPLA and DNDi, where it had abacavir, 3TC, lopinavir, ritonavir in one capsule that you'd open up and sprinkle on food, and it was developed for children. But we thought, well, maybe we can also try to use it in neonates, because it'd be very useful to give 4 drugs and one for neonates as well. So we did a study where we looked at initially single doses of this 4-in-1 formulation in neonates, and there were 60 neonates enrolled. And what happened is perhaps a little bit disappointing. And when we looked at the abacavir and 3TC levels, this is the concentrations, time curves in those 16 infants of abacavir on the left and lamivudine on the south, but they're very hard to look. But if you look at them compared to what children were getting in terms of exposures, the levels were on the high side. When we give that single dose to newborn babies around the first week of life, they would have almost 5 to 6-fold higher abacavir levels. The 3TC would be about 3 times higher. But that's what we expected, because we're giving a fixed dose. It's not, you can't adjust it like a liquid. So we knew that those exposures would be higher because we are giving a higher dose. So that was to be expected. But what we didn't expect is when we looked at the lopinavir levels were extremely low, actually. So again, this is the challenges of when you're trying to, fit something which was defined for children. Children may over 3 months of old, trying to get into neonates, where you have this rapid changes in metabolism, where 2 of the drugs look okay, but 1 of the drugs look not so good, is where you can't give this fixed dose combination. Because if we wanted to change the dose, you would have to give another capsule, but that would mean the abacavir and 3TC would go even higher. But the lopinavir might be okay, but then you've gone too high on the other 2 drugs. So when we looked at that, we said, yes, it was safe, but moving forward would be a huge challenge. So because the lopinavir, we could not really overcome the lopinavir exposures. So we quickly adapted, and with the help of Vitaris, Mylan, they were very kind, Dr. Emanuel's in the audience, who were able to provide us to separate these formulations. So we had access to the abacavir 3TC dispersible tablet. We had the lopinavir granules, which was superb. And then we could give 2 doses of the sachet. So that would be increasing the lopinavir, but we kept the abacavir 3TC the same. And we looked at the single doses of that, and it looked very nice. So we're then able to go on to the multi-dose and give a quarter tablet of the fixed dose combination and the lopinavir sausage, two sachets twice a day. And this is the results, and it's just going to be published this week, actually. And what we saw is, and again, I'll just quickly walk through this. I know it's haven't got too much time, but these are the box sort of individual AUCs across the three different drugs: abacavir, 3TC, lopinavir, ritonavir. And the blue dots and the orange dots is the difference between the first week of life approximately and the third week of life. And if we looked at let's say look at abacavir, and the blue shaded areas is the perfect zone, let's say, to be in. You can see for abacavir, we are getting high levels during the first week of life, but it quickly drops down as we saw with the liquid. You get this quick, rapid turn on. So, by about 2 or 3 weeks of life, the dose was good. 3TC, it doesn't change so much between the first week and third week of life. And lopinavir was much better. We're getting levels within in the right range. So while it's not still perfect, especially if you may be concerned about higher abacavir exposures within the first week of life, it wasn't too bad. In terms of the safety, there was obviously 42 adverse events. There was no deaths. They were all mostly grade 2 and unrelated to the study drug. All of the neonates at the end of the study were HIV negative, and the follow-up is continuing. But clearly, this kind of study with only 16 children where the PK looks good, but the safety is probably not sufficient, we would obviously need to collect more safety data on this kind of strategy, the solid fixed dose combination. So, but in summary, I think if you want to move from liquids, and again, it's probably not something that's going to be used widely because there's other formulations coming through, but it's still a very useful thing to have a strategy available in your pocket. We're using the solid fixed dose combinations of abacavir 3TC dispersible tablet, as well as the lopinavir ritonavir granules. But what about the DTG? People are saying, well, the lopinavir granules is a very important innovation in terms of formulation to get something which was very difficult into a granule. But now we're moving away a little bit into this DTG, and there is DTG studies looking in neonates. There's one study called Impact 2023. It's always quite confusing that because it's not the year, it's the name of the study. So it's always confusing. 2023, that was last year. No, that's the name of the study. But they're going on with that, and they're looking at a DTG suspension and the fixed dose combination. But we're looking with Vitaris as well, as who has donated the DTG dispersible tablet. We're looking at petite DTG now, so looking at DTG in neonates from birth. But we're able to add on a new formulation, this dispersible film of DTG, which is just being produced by Loris Labs, where we'll be studying both of those formulations. And I put one video in of me, you can recognize the handsome guy here, who is taking the oral film. And I'll just play the video and I'll explain. So this is the oral film, and there's a little bit of a cheat actually, because that's a bit smaller than actually what it is. Because I did it once and they filmed it and they didn't press record, so I had to do it again. And I had a lot of saliva in my mouth. So I don't think maybe in a neonate or a younger child, it will disappear so fast, and it will be slightly bigger. But again, I think exploring this in the context of neonates, young children, as along with the dispersible tablet, may be interesting to see how that formulation can help. So that's the neonates. There's some studies going on, and we're interested to see what will come out. But now I think we can look at the fixed dose combinations. We're going to move towards the older children where we are. And this is a study that came out last year, which is on the Triumex, or abacavir 3TC DTG pediatric dispersible tablets, the first fixed dose combination of those, which is for oral suspension. And this was done in the Impact 2019 study. Again, it was not done in 2019. It's the name of the study. And this was looking at this triple drug formulation in children between 6 kilograms and 25 kilograms with the different weight bands you see on the right. And it was for children less than 12 years old. And there was 57 children enrolled. The majority, 2/3 were from sub-Saharan Africa, but importantly, there was a third of them were from Thailand, from the colleagues enrolled in, from sites in this room. And when we looked at the results of this, it looked very encouraging. Again, these are similar figures to what I showed you with the petite, but this is for dolutegravir, the gray zone being the optimal drug concentrations or exposures to be within. And we see that for DTG on this one, on the exposure or the pre-dose concentration, the levels look very good with the dosing that's done. For abacavir 3TC also pretty much within the range. So the weight band dosing they came up with that fixed dose combination for children was very encouraging. Again, shown to be very safe. There was no discontinuations, and the majority who were already on treatment when they switched maintained viral load suppression at 24 weeks. And they were very well tolerated. So with this data now, the US FDA has extended the indication for Bacavir 3TC DTG dispersible tablets for use in children 3 months and more than 6 kilograms. So the next question you might ask to yourself, why 3 months? Shouldn't they go a bit lower? But the FDA has only approved a Bacavir down to 3 months, so they couldn't go lower. And then 6 kilograms, why we don't do the 3 to 6 kilogram range? And there is some people then thinking about investigating that lower weight band. And though there's not many children now, it's still a knowledge gap, I think, with this formulation in the lowest children and perhaps a younger age. But can we access this? And this was data from from CHI, which released an HIV market report every 6 months. And I just highlight one area which is related to this pediatric triple dose combination. So there is generic being produced by Vitaris and Arubino, and they have a price of around about, it seems in the report, around $15 per bottle. So hopefully with advocates in Thailand that we'll be able to also access here, and we'll be able to have this available for children in Thailand. In terms of the other fixed dose combinations that have been around, there is the BF-TAF. And again, this has been around for a while, where they're looking at studies of the adult formulation, so the 60-225 of the fixed dose combination in children down to 6 years old. But they did generate a low dose formulation of Biktarvy, which was 31-2015. And this study has just been completed. Again, colleagues in the room were involved in this study, where they enrolled children between 14 and 25 kilograms. And interesting about this tablet, it's a fixed dose combination that's not meant to be dispersed, but you can split it in half and they can take one half and then the other half. Again, it'd be interesting to get people's feedback about the taste was like, because TAF is supposedly quite bitter. So if they snap it in half, was the taste worse than what we want? Maybe someone can give their experience with that. But at the first part of the study, there are 12 children. It looked good. The PK looked good. The safety looked good. And as I said, this is the palatability. And it's interesting if you look on the first figure with the greens and the yellows, thinking everything is good. But by the week 24, there were some reds, which is unusual, I would suspect. You would have thought it would have been quite, still the same. So it'd be interesting to see why that was, because it is a pretty small tablet as well. But in terms of the remaining, they enrolled more children, and the viral load looked excellent. All of the children where there was data available remains virologically suppressed. The immune response was good. The percent CD4 remained the same. There was a slight drop in the CD4 absolute level, but again, these were younger children who were suppressed, so so it may be expected it, but the percentage was okay. The change in the renal function it did decrease, but this is something that has been seen in the adolescents as well. So that was something that was not thought to be a concern, but it'd be interesting to hear the pediatricians' thoughts on that. And then again, because of all of these studies that people in the room have been doing and beyond, this is now approved down to 2 years and children weighing 14 to 25. And lastly, I'm just going to talk about the long-acting we have. Dr. Linda's going to talk about the long-acting so I've got only one slide on it, but it's talk about rilpivirine in adolescents, where we have this, intramuscular formulation now that can be given every monthly or every 2 months. And it is approved now in children more than 12 years old. There are multiple other studies going on. The CREON study, which I would just like to highlight, is a study that is going to look at children between 2 and 12 years old, looking at rilpivirine for treatment. The CREATE study is looking at rilpivirine in pregnant women. Be the first study to see if you could just give a few injections during pregnancy and breastfeeding, maybe that would protect the infant from and the mother from transmission. And lastly, I personally think I'm very interested in looking at CAB for postnatal prophylaxis. This has been highlighted as well. I see Gunkanya is coming to the stage. How long do I have left? 2 minutes? Okay, I go fast. About 4 more slides, I think, something like that. Lastly, Lenacapavir, a new drug, was interesting data to show that these Lenacapavir, which is an intramuscular subcutaneous injection, can be given with 2 bNAbs. This was in adults for 6 months. The problem sometimes with these long-acting drugs or ultra-long-acting drugs, 6 months, there's nothing much to pair it with. You have Lenacapavir alone, but you need to give it with something else. So having these bNAbs, which last a bit longer, and this was in adults, showed that actually the majority of patients remain suppressed when you give, 1 injection and 2 bNAbs over 6 months. There are some new formulations coming out. There's TLD, which could be maybe an injection once a month. A lot of our your patients are on daily TLD, but there are people looking at see if you could give it longer, once a month injections, or long-acting bictegravir is coming available. So again, getting these ultra-long combinations with drugs that we give orally now are being developed. And lastly, I have the BNAbs, where we're trying to see if you could suppress infants who are biologically suppressed. This one is in adults, where they give 2 BNAbs and then they stop the ARVs and give 2 BNAbs for 6 months, and all 7 adults remain suppressed. So that's pretty impressive that you can do that. But in children, they tried it with different BNAbs. One of the different BNAbs, they tried, children who were treated very early, suppressed, give them 2 BNAbs, and then actually in this case, only about 50% remain suppressed. So it's different to the adults, but again, it's still, I would say, a proof of concept that giving BNAbs, we don't know the right combination or the number of combination yet, but it could be a new strategy for that. And I have 2 more slides, but I want to move the BNAbs now back to my home, which is on the neonate side, where, BNAbs has been approved in adults, as I just showed, but actually BNAbs is one of the first ARVs or potential ARVs that might be approved in neonates before even the adults, because you can use the BNAbs also for prevention, for high-risk mothers or, PMTCT. So there are studies ongoing on these relatively old BNAbs now, like BCR1, where they have been looking in infants as well. So my closing thoughts, sorry to rush towards the end, but I'm trying to keep within time. So there's still residual infant transmissions. We saw still 130,000 last year. Breastfeeding is still a major problem where we need interventions during the breastfeeding, which is obviously not a problem for Thailand, who use a lot of formula milk, but in other settings, it's still an issue. There are new formulations for neonates. We have the bacavir liquid, the lopinavir ritonavir granules, dispersible tablet, and potentially dolutegravir formulations going forward. So there are some new options. Again, they're not perfect, but again, it's just giving you the tools so that you can decide what was the best for your individual patients. It's excellent that we have these fixed dose combinations now, the BALD or Biktarvy, if we can access them. And of course, the long-acting is where we want to really go to study these BNAbs or small molecules like cabotegravir and lenacapavir, etc., but in the children, to see if we can make their lives easier so that they can continue to grow up without worrying about anything to do with long-term disease. And with that, I'd just like to thank the Petite study participants and the pharmaceutical companies, Vitaris, Loris Labs, and Cipla, who are providing the drugs. So thank you very much.
Well, thank you, Tim.